Hello, and thank you for tuning in. My name is Dr. William Braaksma, and I'm going to be presenting the good news for bad knees. I'm an orthopedic surgeon practicing at Orthopedic Associates, and I perform Mako robotic total knee replacements and partial knee replacements at McLaren Port Huron Hospital. I have no financial disclosures. I'd like to talk a little bit about my background and training and how I got to Port Huron as a board certified orthopedic surgeon specializing in total hip and knee replacements. I graduated with honors and Alpha Omega Alpha Honor Society from Wayne State University Medical School in 2009. After graduating from medical school, I attended a 5-year orthopedic surgery residency in Grand Rapids, Michigan, with a partnership between Spectrum Health and Michigan State University. After graduating from residency, I completed a 1-year foot and ankle fellowship at the University of Washington School of Medicine in Seattle from 2014 to 2015. In 2020, I had the opportunity to further my training with a 1-year, highly advanced total hip and knee replacement fellowship at the Cleveland Clinic, Florida. While at the Cleveland Clinic in Florida, I gained training in Mako partial and total knee replacements and direct anterior hip replacements. I also learned techniques in revision hip and knee replacements, which involves fixing failed hip and knee replacements. During the course of your training, you get several certificates and diplomas, and I just wanted to share several that are particularly important to me. The first is my diploma from my Total Joints Fellowship at the Cleveland Clinic, Florida. Having been in practice for 5 years, I went back to school, so to speak, to complete this fellowship, which was very difficult, especially with a small family. And this is a picture taken on my last day of training at the Cleveland Clinic with my 3 children there to share that experience with me. The second piece of paper that I'm particularly proud of is my American Board of Orthopedic Surgery diploma. Every orthopedic surgeon that becomes board certified must present 15 surgeries that they've completed in their second 6 months of practice before a panel of board certified orthopedic surgeons. Those orthopedic surgeons critically review the surgical procedures so that a board certified orthopedic surgeon meets the most high quality as approved by the American Board of Orthopedic Surgery. So that's another diploma that I am particularly proud of. And then the last diploma that I'm particularly proud of is being a fellow member of the American Association of Hip and Knee Surgeons, or ACHIS. This is a professional society of surgeons who have devoted their clinical practice to total hip and knee replacements. My current practice focuses on primary and total hip and knee replacements. I perform my knee replacements with Mako robotics, and my total hip replacements are primarily done through a direct anterior approach. I also have a very busy revision total hip and knee replacement practice, which involves fixing failed hip and knee replacements that have failed for a variety of reasons. I also enjoy a general orthopedic surgery practice and am very busy fixing fractures. The topics for this webinar are going to include a review of the basic joint anatomy, understanding the most common causes of joint pain, discussing both non-surgical and surgical treatment options, and then talking about the different ways that we do joint replacements and some of the recovery expectations once you get a total joint replacement. Your joints are involved in almost every activity that you do, from simple things such as getting up out of the chair and walking across your house to more active things like running and jumping, golfing, swimming, and doing yogas. Having healthy joints allows you to do these activities without pain. The normal joint has multiple soft tissue and bony structures. This is a cartoon picture showing both the bony structures in the knee and the surrounding soft tissues. The ligaments are strong elastic bands of tissues that connect bone to bone. In the knee, there are 4 primary ligaments: the medial and lateral collateral ligaments, and the ACL and PCL. In addition to ligaments, there is cartilage, which is the white surface on the ends of the bone. That is the bearing surface. There are no nerve endings in cartilage, and it is the best bearing surface on the planet. We cannot manufacture a better bearing surface than human cartilage. It allows joints to move without pain. The meniscus are fibrocartilaginous discs that are C-shaped and sit between the ends of the bone. These act as shock absorbers and help to further stabilize the knee. They can become torn, which forms another cause of knee pain. Tendons are the soft tissue structures that attach muscle to bone. They're tough bands of fibrous connective tissue that, again, connect muscle to bone. So when a muscle contracts, that's what causes the joints to move. Around the knee, there are multiple tendons, including the quadriceps tendon and the hamstring tendons. The knee is a synovial joint. It includes the distal articulation of the femur to the tibia, and also the kneecap or patella to the distal end of the femur. The synovium, or the lining of the joint, produces fluid which lubricates the joint and allows it to move. There are multiple causes of pain around the knee. There are more minor things, such as sprains or strains or meniscus tears, which generally follow a traumatic injury, or things like tendinitis. Tendinitis is generally an overuse symptom of things like running or being active. And then bursitis. Bursitis can have several different causes, including overuse or occasionally infection. Signs and symptoms of knee arthritis include things like warmth, swelling, pain, and decreased function. While there's many ways to make a diagnosis, one of the most important ways in making a diagnosis is things that requires no imaging, things like a history and physical exam. As a physician, I can glean lots of information by simply talking to the patient. Where is your pain? How long have you had your pain? What type of activities cause pain? And physical examination. By actually examining the knee and palpating or touching different areas of the knee, you can get lots of information that help you come to a diagnosis without having any type of advanced imaging. The most common cause of knee pain is osteoarthritis. This is, again, the most common form of arthritis in adults. It is related to aging or injury and is wear and tear. I like to think of osteoarthritis as a degenerative process similar to the tread on your tires of your car wearing out as you get increased mileage. As I mentioned previously, cartilage is one of the best bearing surfaces on the planet. There is no nerve ending in cartilage, so it allows you to move your joints without pain. As that cartilage breaks down, the adjacent bones begin to rub together. This creates pain. In addition to the bones rubbing against each other, the joint produces extra fluid in an attempt to lubricate the joint, and the bone also forms bony growths called bone spurs or osteophytes, which can cause impingement, tenderness, and can further restrict motion. This whole constellation of processes causes pain and restricts movement. People who are at risk of developing arthritis are people that are elderly or older. Occasionally, an injury or fracture can cause what we call post-traumatic arthritis, where an injury, break, or tear cause progression of degenerative changes. Overuse can cause arthritis. Obesity can cause arthritis due to the extra stress that the increased weight puts on the joint. There's a component of muscle weakness or deformity that can cause arthritis. Hereditary issues also arise. Many people will say that they have a family history and there's some component of genetics that plays a role. And then there are some sex differences between men and women, where women are more likely to develop arthritis than men. This is just a cartoon showing the differences between osteoarthritis and rheumatoid arthritis. Osteoarthritis, again, is a degenerative process where, with time, the cartilage bearing on the ends of the bone wears away. You'll get degenerative tearing of the meniscus, the joint space will narrow, and the body will produce bone spurs. This process causes pain and decreased function. Rheumatoid arthritis is an inflammatory type of arthritis where the body's immune system reacts and the synovial lining of the joint becomes inflamed, and that process damages the articular cartilage. While the underlying mechanism is different than osteoarthritis, the end product is the same in that the cartilage bearing surface wears away from the ends of the bone and creates pain and decreased function. After a physical exam and history, X-rays are the most common imaging study used to make the diagnosis of arthritis. Figure 1 shows a normal knee. Between the ends of the distal femur and tibia, or the thigh and shin bone, you can see space. That space is articular cartilage. Articular cartilage is mostly water, so on an X-ray, cartilage shows up as a clear space between the ends of the bones. In figure 2, you see a joint with more moderate or severe arthritis. The classic finding of osteoarthritis on X-ray is joint space narrowing. The cartilage bearing surface has worn away and you get bone rubbing against bone. You can also see bony prominences along the medial joint line from bone spurs. That is a classic finding in knee arthritis. In addition to X-rays, there are other tests to help come to a diagnosis and also rule out other causes of pain. Blood tests can be used to make the diagnosis of things like rheumatoid arthritis. An MRI is a frequently used imaging study by orthopedic surgeons, and on the screen you can see a sagittal cut of an MRI of a knee. An MRI will also show arthritis and degeneration of the joint surfaces, but in addition to arthritis, it shows the soft tissue in much greater detail. You can see things like the tendons and the meniscus and the muscles around the knee joint. Bone scans, while generally not used for managing somebody with arthritis, can be very helpful in working up somebody that has a painful total hip or total knee replacement. You should see an orthopedic surgeon when you have persistent pain or stiffness, commonly after getting out of bed in the morning, soreness and swelling in the knee, recurrent or persistent pain and stiffness, weight loss, fatigue, and or fever that is accompanied by your joint pain. If you're having problems with your joints that are interfering with normal daily activities and have failed to respond to home remedies, if you find yourself avoiding doing things that you previously enjoyed doing, like going to church, walking, or shopping, if your joint pain is interfering with sleep, or you find that you're avoiding social activities because you don't want to slow everybody else down, those are all types of things that you should consider seeing an orthopedic surgeon for. There are some home remedies that you can do, including the RICE mnemonic. RICE stands for rest, so avoiding things that aggravate or make your knee painful. ICE, icing the inflamed and painful joint can help. You should ice for no longer than 20 minutes at a time. Using compression, either with an ACE wrap or compression socking, and elevating the involved extremity. This can help particularly with an acute flare-up of knee pain. We always start managing patients that have knee pain, whether it be from arthritis or other causes, with conservative treatment. Conservative treatment means non-surgical. As long as there are not medical issues like chronic kidney disease or stomach ulcers, anti-inflammatory medications, either over the counter or prescription strength, can be very helpful. Common examples of NSAID anti-inflammatory medications include things like Motrin, Advil, and Celebrex. For patients that have kidney or stomach issues that prevent them from taking an oral anti-inflammatory, there are topical anti-inflammatory gels. The most commonly used is an over-the-counter anti-inflammatory gel called Voltaren gel. These medications can help to alleviate some of the symptoms associated with arthritis. Using a walking aid, such as a cane or a walker, can help to offload a painful joint. Physical therapy is another great option for patients with arthritis. A physical therapist is a healthcare professional that can, in addition to treat, can help make diagnoses of your knee pain. Goals of physical therapy include reducing pain, restoring function, improving mobility, preventing disability, and educating patients. One of the other ways that we try to treat knee arthritis is with weight loss. I have two more X-rays of a healthy knee showing joint space and an arthritic knee. Weight is transferred through the knee with normal walking, where the knee sees 3 to 4 pounds more of pressure. Going up and down stairs or getting up out of a chair, 5 times the body weight goes through the knee. And with running, 9 times the body weight goes through the knee. So for every pound you lose, you can take 4 pounds of pressure off the knee. One of the more common non-surgical things that both orthopedic and other providers will employ are injections. The most common type of injection is a cortisone or steroid injection. The steroid or cortisone is usually mixed with a local anti-anesthetic like lidocaine and is injected into the knee. This very powerful combination of steroid and numbing medicine helps to reduce pain and inflammation. It will not build back cartilage, but it can help to alleviate some of the symptoms associated with arthritis. It is one of the more commonly used treatments, and it is very safe and effective. It is well tolerated by most patients. There are other less common types of injections. One of the most frequently used for arthritis is viscosupplementation. These are hyaluronic acid type injections that help to reduce inflammation and quote unquote lubricate the joint. These are the so-called rooster comb or chicken fat injections. And there are a variety of different types that can be used with decent success in alleviating the pain from arthritis. Less commonly used injections include things like PRP or platelet-rich plasma and stem cells. And these are emerging treatment options for patients with arthritis. After non-surgical things fail to improve knee pain, there are other non-joint replacement surgeries that can be used in certain patients. One of the more common non-surgical, non-joint replacement surgeries is an arthroscopy or a knee scope. The most common indication or reason to have a knee scope is a torn meniscus. When the meniscus tears, it can create a painful nidus that pinches between the ends of the bone. The analogy that orthopedic surgeons like to use when describing how a meniscus tear creates pain is a hangnail. Similar to a hangnail, the torn meniscus will not heal. So going in with a camera and small arthroscopic instruments, the torn portion of the meniscus can be debrided or removed. Arthritis, because it is a degenerative process where the cartilage wears away, generally can't be treated by an arthroscopy. But for patients that have a symptomatic meniscus tear, an arthroscopy is a good alternative to a joint replacement. Once patients fail non-surgical treatment, the surgical options for severe arthritis of the knee is either a partial or a unicompartmental knee replacement or a total knee replacement. I like to talk about thresholds. Every patient has a different threshold for what they can tolerate in terms of pain and limitations in activity. While an orthopedic surgeon is a very good resource in helping determine when a patient is ready for a joint replacement, it should ultimately be the patient's decision to go forward with surgery. I think that knee replacements are wonderful surgeries when patients come to that decision on their own with the help of an orthopedic surgeon. This is an example of a patient that had arthritis in one compartment of their knee. So on the plain film X-ray, you can see narrowing of the inside compartment of the knee, while the outside or lateral compartment has well-maintained joint space. In this particular subset of patients, a partial knee replacement is an excellent option. There are different types of partial replacements. The knee has 3 different compartments that can be replaced. The majority of partial replacements that are done are of the medial or inside compartment, but the lateral or outside compartment or the patellofemoral or kneecap joint can be replaced. Occasionally, we will do a bicompartmental knee replacement where 2 of the 3 compartments are replaced and the lateral compartment is left unresurfaced. This is relatively uncommon, however. When arthritis is more widespread and involves the entire joint, or there is deformity, the treatment is with a total knee replacement, which involves resurfacing all 3 compartments in the knee. There have been multiple recent advancements in technology that allow surgeons to improve the accuracy and how they perform partial and total knee replacements. Mako is a robotic arm assisted technology that provides the surgeon with greater accuracy and precision when fitting and positioning the implant. Mako gives the surgeon a 3D anatomical map based on the patient's unique anatomy after a CT scan is obtained before surgery that allows the surgeon to very accurately remove only the diseased portion of the bone and leave as much healthy bone and soft tissue as possible. The surgical system also assists the surgeon with placement of the knee implant, ensuring proper placement and fit and soft tissue tension. How it works for joint replacement includes starting by getting a personalized surgical plan. Prior to surgery, a CT scan or CAT scan is obtained of the operative leg. This allows the surgeon to get an idea of where the arthritis is, what size implants the patient needs, and any particular challenges that there may be with the surgical procedure. During surgery, the saw or burr, which is under control of the surgeon, allows removal of only the arthritic bone. With trial or temporary implants in place, the surgeon is very accurately and objectively able to determine range of motion assessment. And finally, the software allows very accurate and precise placement of the implants. These are some of the pictures that are available to the surgeon during surgery. This is the CT scan that is specific to the patient and shows all of the landmarks in the knee in gray, and the green is the implant. So before even making a bone cut, the surgeon can see how the implant will sit relative to the patient's unique anatomy. And then with the implants in place, the surgeon is very accurately able to tension the soft tissue so that the patient has optimized range of motion and balance of those soft tissue structures. This screen shows how the surgeon is able to see the patient's deformity, what their range of motion includes, and then how to optimize implant position so that the soft tissue is very accurately restored to its native tension. After the surgical plan has been made, the Mako robotic arm allows very accurate removal of only the diseased bone. On the screen with the majority of the tibia covered in green, you can see the blue saw, how it removes only the diseased portion of bone. As the bone is cut, the green goes away, so the surgeon very accurately can see where they still need to cut. The green outline are haptic boundaries. If the saw travels outside of these boundaries, it will turn off. This is a safeguard to prevent cutting things that shouldn't be cut during surgery. Once all the cuts have been made, trial or temporary implants are placed on the ends of the bone, and the surgeon is very objectively able to see if they've accomplished their goals in terms of restoring alignment and properly tensioning the soft tissue. One of the major benefits of Mako robotic surgery is that if the surgeon, after making their initial bone cuts, would like to change something, they can very quickly and accurately make recuts to further improve the balance and position of those implants. This is a screen that I like to show, and I think demonstrates the power in technology and innovation. Around the time of the Apollo missions, knee replacements started to be developed in New York City by a doctor named Dr. Insall. Over the years, there have been multiple innovations in the way that we send astronauts into space. And I like to think that Mako, or robotic knee surgery, parallels this in allowing a much safer and accurate way to do the surgery. Recovery from a total joint replacement. Following surgery, you will work with your medical team to set goals and determine a recovery plan that's right for you. Every person and individual is unique and every treatment plan is different, but there are some general recovery timeframes that we will tell to patients. Most patients following a routine primary total knee replacement are in the hospital for one night. There has been a growing trend, however, on discharging patients with appropriate pain control the same day. Partial knee replacements are generally able to go home the same day of surgery. Daily activities usually resume anywhere from 3 to 6 weeks following surgery. Walking will start the day of surgery. It's also incredibly important to start range of motion so that the knee doesn't get stiff. Full recovery typically takes 6 to 12 months. I like to tell patients that by 3 months, most patients are very happy and are able to return to full unrestricted activity. Joint replacement has the potential to get you back to what you love. It's important to remember that joint replacement will not allow you to do more than you could do before your joint problems develop. Activities that patients typically are able to return to include walking, biking, swimming, dancing, and golfing. There are some limitations after a joint replacement. While the surgery is remarkable in its ability to replace the replaced joint is still ultimately metal and plastic. It can wear and have issues if extra stress is placed on those metal and plastic implants. Some activities that patients should strongly consider avoiding include things like running, contact sports, basketball, and jumping. Skiing is listed, but I tell patients that cross-country skiing is fine, and there's also been some recent literature in the orthopedic journals that show downhill skiing is safe after a knee replacement, and that a large number of patients that were downhill skiing before a knee replacement are able to return to downhill skiing. I'd like to finalize by showing some cases that I have done. This is an X-ray of a left knee showing isolated joint space narrowing on the inside or medial compartment of the knee. This particular patient had pain isolated to the medial compartment. This patient was an excellent candidate for a partial knee replacement. So you can see on these X-rays that only the medial or inside compartment of the knee was replaced. This was done with Mako robotic surgery at McLaren Port Huron Hospital, and the patient was discharged home the same day and did very well in follow-up. This next X-ray is a more common X-ray of more widespread or severe tricompartmental arthritis of the knee. This patient underwent a total knee replacement using Mako robotic surgery at McLaren Port Huron Hospital and also did very well. This patient was discharged home the morning following surgery and did very well. This is a revision knee replacement. This knee replacement was done previously and was found to be unstable. The medial collateral ligament, or the ligament on the inside of the knee that stabilizes the knee, was grossly loose. The patient's knee was giving out and causing pain and recurrent swelling. This was done manually or without Mako. This is a revision or redo of a knee replacement. The knee replacement that had been previously placed was removed, and revision implants with stems, cement, and metaphyseal cones were used to get good fixation, and a more constrained implant was used to allow the knee to function more normally and have stability. This patient was admitted for 2 nights after surgery and did very well. My goals as a surgeon include making a shared decision in the office. As I mentioned previously, deciding to go forward with a joint replacement is a very personal decision, and I think that it is ultimately up to the patient to make that decision. As an orthopedic surgeon, I like to consider myself a consultant to helping a patient make a shared decision on when or what type of treatment they would like to pursue. I try to practice medicine with the highest quality and evidence-based care, doing things that are up to date based on the most current orthopedic literature, the latest treatments, and things that are talked about at the National Orthopedic Total Joint Replacement meetings. I also aim to provide care similar to the care that is provided at an academic center. Again, by providing high quality, evidence-based care with the most up-to-date information available. I also demand perfection of myself in the way that I execute my surgeries. I think that Mako, in particular, is one way to chase perfection. I demand perfection in myself and those that I work with. I also hope to be accessible to my patients. Finally, I would like to provide compassionate care similar to how I would want my family treated. In summary, I think it is absolutely critical to get a correct diagnosis. In regards to knee pain, this is generally done with a history, physical exam, and X-rays. I think it's critically important for patients to be informed and to know their options. Patients with knee arthritis have multiple options, whether it's something as simple as observation if the knee pain is not bad, or things like a steroid injection, activity modification, and an anti-inflammatory like Motrin, or something like a knee replacement. Finally, I think when pain starts interfering with the things you enjoy, get help. Whether that's from your primary care physician or an orthopedic surgeon, there are lots of options, both non-surgical and surgical, that can help you getting back to do the things that you enjoy. Finally, the most important things in my life are my family. I have 3 children, aged 6, 4, and 2, and a beautiful wife who is a nurse at McLaren Port Huron Hospital. Thank you so much for turning in, and I would be more than happy to be a resource for you and your knee pain in the community. I practice at Orthopedic Associates, and I've listed my office address and telephone number, and I perform Mako, robotic, partial, and total knee replacements at McLaren Port Huron Hospital. Thanks again, and have a great day.